Okay. All right. Can everybody hear me? Everybody's good? Okay. Um, Good morning, everyone. I just want to let you know before we get started, bathrooms are to our left if you're in person. If not, ask one of these Murray guys and they'll show you where the bathroom's at. For those of you in person, welcome to Station 81. For those of you online, thanks for tuning into our 2B Protocol trauma update. I'd like to welcome some of the people who are here attending and give a special thanks. Jamie Troyer, Teresa, and then Ross Fowkes. You guys have been an amazing help to get these protocols up and running. And then as well as the trauma surgeons that are here in the room. Thank you guys a lot. So first, we're going to start with the most recent updates, and then we'll go over reviewing the protocols. And following that, we'll open things up for Q&A, and Teresa will introduce the trauma surgeons that we've got here today. To get things started, I'm Sam Pasqua. I'm honored to be here and a part of our newly formed 2B Protocol Writing Committee. Before we start the updates, I wanted to give some background to the committee that we've recently formed. About a year ago, the need arose to address some of the 2B protocols and work on not only updating, but also adding and revising ones that were already in place. Chief Travis Botcher, paramedic Stephen Greenwell, and I volunteered and had been tasked with looking over the protocols to find errors and compare them to state protocols that were already in place. As we looked, it became apparent that this was a much larger task and would be best served with representation from other agencies that 2B serves to give their respected feedback and suggestions. The search began to find the right people to accomplish this mission and to capture different areas across the Salt Lake Valley. I'm honored to say that Murray's Stephen Greenwell, South Jordan's James English, Salt Lake City's Addie Miner, Salt Lake City's Dan Harris, and West Valley's paramedic Chase Judd have all stepped up to the plate and have been amazing to work with. With all these paramedics in place, actively correcting protocols and brainstorming ideas to simplify our guidelines, they also act as an avenue for people to bring issues to. We've made substantial improvements and even created some of the new protocols to better help the boots on the ground, which is why we're here today. After identifying errors in the protocols and starting to fix them, which is still very much ongoing, we were also given the task to create new trauma protocols to combat the growing number of traumatic injuries that are occurring across the Salt Lake Valley. In conjunction with trauma surgeons from IMC, University of Utah, and St. Mark's, we've created 2 new protocols that were just published and ready to be utilized on the streets. On the screen, you'll see both a new penetrating trauma management and a new general trauma management protocol. The purpose of these guidelines is not only to separate the differences one might face regarding mechanism, but also provide guidance on how we should manage each of these independently to do right by our patients. As we look over these protocols, please take a minute to note any questions that you have for either our committee or, better yet, any of the smart docs that are in the room today. And thanks again for helping us create these. So now we'll take some time, Chief, if you'll just go back to the top, and we're just going to scroll through each of these different protocols, talk about some of the key differences and kind of why we made these changes. So as you guys can see here, we're looking at our penetrating trauma management. The goal with our committee was to separate how we treat penetrating and how we treat blunt trauma management. Obviously knowing that these are 2 very separate things and require different treatments. The changes that we made first and foremost were to go through at the top, put in key considerations and things that would immediately change patient outcomes. So as you can see in the blue in 2B protocol is now meant to signify a change that was recently made. And the goal is to have these removed after they're up on the page for a month so that everybody can take time to see what changes were made and obviously to alter their practice. So in the key considerations, I'm not going to read these aloud, but you guys can see one of the big things we made was specifying time on scene and how quickly or not quickly we're going to transport these patients. We also talked about withholding resuscitative efforts, obviously knowing that penetrating trauma has a pretty significant chance of survival and our blunt trauma patients may not have as good of a chance. Do you mind scrolling down a little further, Chief? And then going through afterwards, we wanted to identify each different body component and how we would treat these, and also refer to other protocols that are already in place. For example, the head injury and TBI guideline. Alrighty. Yep, a little more. All right, and then as we get down to the bottom, you keep going, Chief, if you don't mind. As we get down to the bottom, we get into the basic, advanced EMT, and paramedic treatments. I'm going to give the docs a little time later to talk about the new changes in TXA, or tranexamic acid. But as you can see, we're now approved to give 2 grams in a 100 ml bag over 10 minutes versus the old protocol, which was usually just 1 gram. Alrighty, and then obviously down here, we're going to talk about signs that somebody needs to be needle decompressed, and then also penetrating traumatic arrest. All right, do you mind going to the general? So that's our penetrating trauma. I encourage all of you guys that are here online to please look at that and note the changes that we've made. And now getting into the trauma management, this is kind of just the same thing as the penetrating, where we put our significant changes up at the top. Talk about, obviously, if anything involves penetrating trauma, then refer to that guideline. But general trauma was meant to absorb the rest of the trauma and talk about that and just separate penetrating. Again, down here, we're going to talk about time of onset, greater than 15 minutes, immediate transport, and continues all interventions en route. But as we get lower in the protocol, it's going to be pretty similar to the other ones where we're talking about airway, breathing, circulation, treatments provided. But down at the bottom is kind of where I just wanted to point something out for everybody. So right here at the bottom, withholding and termination of resuscitative efforts. So the goal with penetrating management is that we transport these patients quickly and perform and treat life threats on the way. Difference with blunt trauma is we do have this part at the bottom that talks about withholding and termination of resuscitative efforts. In the blue, just gives kind of our goal scene time, transport to the nearest facility, and then obviously somebody that's actively in arrest, how we should proceed with taking care of these patients. I think we'll leave these up on the screen for a little while. Does anybody have any questions for me or our committee until we pass it over to Teresa and then the trauma surgeons? Go ahead. These are up. Yep, these are actively up right now. Anybody else? Any questions for us? Okay, cool. I'll pass it over to Teresa and she'll introduce all our trauma folks. Yeah, if you guys wouldn't mind all the trauma docs coming to sit up here. Where's this?
Thank you. I'm just gonna stand right there. Okay, I want to take a minute just to have introduce Mark Herrera. Even though he's not on the panel, we want to acknowledge that he's here. Mark has 13 years in the emergency medical services. Do you want to stand up, Mark, so they know who you are? Sorry. He works as, I say, Director of EMS Education, Licensing, and Specialty Care at the Utah Office of EMS. This is from 2020's bio, so if it's changed, you'll have to correct me. I told Jamie, I'm really good at making these up, you know. He's part of the team that oversees EMS in the wonderful state of Utah, which includes EMS education, licensing, training, protocols, and specialty care systems. He was a field paramedic in a rural EMS agency. He responded to 911 emergencies, helped write the protocols, provided in-service trainings, and was over the field of training program for new employees. When he's not working, he loves being outdoors, cooking, playing with his daughters, and sports, and enjoying family time. So thanks for being here, Mark. Okay, on to our panel. I have Dr. Ennis. Raise your hand. Okay. Dr. Ennis he joined the Department of Surgery at the University of Utah in 2010. He's currently an associate professor of surgery and the trauma medical director at the University of Utah Trauma Level 1 Trauma Center. Dr. Ennis was born and raised in Sandy, Utah. He graduated cum laude from the University of Utah with a degree in mathematics and subsequently earned his doctorate of medicine from the University of Utah School of Medicine. I didn't make this up, by the way. He completed his general surgery residency, surgical critical care fellowship, and acute care surgery fellowship at Wake Forest University Baptist Medical Center in Winston-Salem, North Carolina. Dr. Ennis's clinical expertise is in the areas of trauma surgery, emergency general surgery, and the surgical critical care In addition to his work in acute care surgery, he maintains an active practice in elective general surgery. As trauma medical director and director of the acute care service, Dr. Ennis has been instrumental in developing all facets of the acute care surgery system at the University of Utah, clinical education and administrative and research. Dr. Ennis is active in acute care surgery at national levels through his involvement in the American Association for Surgery of Trauma and the Eastern Association for the Surgery, EAST is what we call it. His involvement includes committee services, clinical guideline development, and multiple institutional research studies through these national organizations. Was that well enough? Is there anything I missed? Okay. Next up is Robert Bob Sheen, born, you want to raise your hand so we know who you are? He was born in Salem, Utah, graduated with his BSN from Westminster College in 1998. In 2005, he became a board-certified family nurse practitioner with a Master's of Science in Nursing from Westminster. He began his trauma NP career at the University of Utah and then moved to Utah Valley Hospital, where he was instrumental in earning their ACS Level 2 trauma designation in 2007. Later, Bob supported Jordan Valley in becoming a state-certified Level 3 trauma center. He has worked at St. Mark's Hospital for more than 8 years. He assisted in our verification as an ACS certified Level 2 center in 2017. He is well known at St. Mark's for his passion for educating nurses and EMS. Trauma Bob, is that what I hear you're called? Okay. When he's not working on the ICU trauma service or in the ICU, he can be found on the nearest golf course losing his ball. Last but certainly not least is Dr. Michael Long, graduated from the University of Denver with a degree in biochemistry and molecular biology. He received his medical doctorate at the University of Texas in Galveston and completed his general surgery residency at Baylor College, okay, go back here. Baylor College of Medicine in Houston. They don't make these easy. Dr. Long then pursued a fellowship in trauma, acute care surgery, and surgical critical care at Oregon Health and Science University in Portland. We enticed him down here to join our trauma team in 2020. He's currently the medical director of Trauma EMS Outreach and Injury Prevention and oversees Trauma Grand Rounds, a weekly educational series. Dr. Long has brought his passion and commitment to improving pre-hospital care and strengthening relationships with our EMS providers. In his downtime, he works on his many cars, enjoys hiking, skiing, fishing, and spending time with his dog, Chase. And is Hillary online?
I am. Hey, how's it going? Sorry, I'm not there in person.
Okay. So Hillary, the voice you hear in the room, I like how she says, you don't have to give me a fancy intro. We love Hillary. She's a professor, yeah, spit it out, good grief. Professor pediatric emergency medicine physician at Primary Children's Hospital in the University of Utah. For the love of Pete. You want to repeat that, Hillary? Anyway, we appreciate you joining us and thanks for your help with this. I don't know if one of you need that.
If you did, oh, you got
We've got one.
So,
you.
I'll start us off with a question. So, Hillary, I know that you're joining and you're kind of driving, or other meetings are pressing. So I'm wondering if there's any guidance for pediatric PXA, what the research shows there, and if that would be something that we see in the future, having the dose versus just online medical control direction.
Yeah, thanks. This is a topic that keeps coming up. Can you guys hear me okay?
Yes.
I got a little echo. So we looked at this a bunch of times, and what I can say is that it's not great in pediatrics, but it's not bad either. So when you review all the studies, most of them are on adults, and some do include kids 16, 17, 18. There are a couple combat trials, mostly out of Israel, and one civilian trial called a MADIC trial, and a couple other single center trials that have looked at TXA. And all of them show that there may be a benefit and there does not seem to be harm. So I looked through the literature again today, and I with I think the blessing of my trauma surgeons feel that it is safe to give TXA in pediatric patients if it's given just like adults within 2 to 3 hours of injury time. and then we give the appropriate dose. The only danger seems to be really high dosing in pediatrics with seizures. But if we give a loading dose of 15 milligrams per kilogram, maxing at the adult dose, and we have a known injury time, we give it within, definitely within 3 hours, ideally as fast as possible, then I don't think there's any reason not to give it. We use it all the time as part of our mass transfusion, and we use it for things like bleeding TNAs and very heavy menstrual bleeding. And so I think we feel really comfortably. We use it for spine surgeries and open heart surgeries. And I think we feel pretty comfortable in peds. We don't see a high risk of thrombosis. That's always one of the other things people worry about. So my recommendation would be, and this is what one of our trauma medical directors just talked about as well, that we would give that loading dose of 15 milligrams per kilogram. And then you would max at the adult dose, which I think is a gram. I may be wrong. And then just making sure we're within that injury time frame. I can send you guys the research on it. If anyone is interested, I'm happy to send you like a little compilation of a research review. And then let me know if any of the surgeons there have any different opinion. Please speak up if you have a different opinion on TXA and peds.
So I think from, I mean, the big question is, the question was more directed at the pediatric population. I think in the adult population, what we've seen is there's been a lot of enthusiasm to apply TXA broadly, more broadly than what has been supported by the literature. Really what the literature has supported is early administration within 3 hours in the setting of hemorrhagic shock or exsanguination. That's kind of the key, and that's the difficult thing to distinguish in the field is, do you have somebody who's unstable and hypotensive in front of you because they are exsanguinating, or is it because they have such severe polytrauma that they have a significant inflammatory response system-wide that's leading to their instability. Outside of that time window of 3 hours, it becomes a little bit more murky, particularly in blunt polytrauma. That's been the one area that we've been concerned about being too aggressive in applying TXAs. We don't know, we haven't really defined well the thrombotic risk in blunt polytrauma patients outside of that 3 hour window. There's a lot of literature and research out of the University of Colorado in Denver about the physiologic response to trauma, and 2 ends of the spectrum being what's called fibrinolytic shutdown, or where the body basically stops breaking down blood clot, which is what we tend to see in blunt polysystem trauma, where you get micro thrombosis of contused and injured organs, versus hyperfibrinolysis, which is what you tend to see more in hemorrhagic shots, somebody who has been shot or has significant external bleeding, sometimes even internal bleeding. Those are really the patients that benefit from TXA. What we haven't been able to define well is the patients on the side of the fibrinolytic shutdown, the blunt polytrauma patients. Are they at increased risk of adverse events from the TXA? And so we've really been pretty firm in saying, okay, within that 3 hour window, you just got to treat what's in front of you. And if you're suspecting hemorrhagic shock, then definitely TXA is beneficial. But it's really once we start moving outside of that 3 hour window that we don't have really solid answers for as of yet.
I totally agree.
I have a question with, excuse me, dosing for TXA. Now that we've shifted to the 2 grams for adults in TXA, the math doesn't math very well with 15 milligrams per kilogram for kiddos to get up to that 2 grams. At what point do we stop the pediatric dosing and just say 2 grams? Because there's a pretty significant gap.
Yeah, you're right.
For the 80 kilogram, ends up being 1,200. You know what I mean? So how do you go about that?
Hillary, did you hear that question?
I did. Can you guys still? So I would say, if you get to what you would consider an adult size, so probably, 45 to 50 kilo-ish, you could just go with the adult dose. If you've got a pretty pubertal person, a lot of people define greater than 15 as adult for trauma. I would be fine giving the adult dose. I think we just don't want to give the kids a really heavy dose. And so I think if you're sticking to the 15 milligrams per kilogram for the less than 15s, that's probably great. And then once you're getting to that adult patient size and physiology, switching to the adult 2 grams is great.
I would imagine in the field, oftentimes you don't know the age, you just know kind of the size and the build of the patient in front of you, I'd imagine. There was a question in the back there.
Typically doesn't address like a combative head injury protocol. Back in the days, we were taught 5 to 10 milligrams of Versed. Has anything changes, or what would the hospitals like to see as far as that goes if we do have a combative head injury?
Can you repeat the question just so they can hear it online?
So the question is in
Ross?
regards to a suspected combative head injury, giving Versed, and if any of that has changed. I know that there's been a big shift toward ketamine in the pre-hospital setting. I think that's fine. We've only come up against issues with ketamine in really significantly high doses. That can change hemodynamics enough to where it can compromise cerebral blood flow, and that would be one consideration in potential head injury patient. But you're not going to be getting to those levels unless you have an intubated patient that you're using the ketamine continuously for sedation, really.
Can those be more appropriate for like a head injury then? I would do 1 milligrams for a site, but it's 0.25 for a pain dose IV. Is there a preference on what you guys would like to see? And is there any chance these will be on 2 protocols that we further investigate, like learning as field employees?
In regards to ketamine specifically, again, you're not likely to get up to the significant levels that would be impacting cerebral blood flow. So more whatever is effective to keep the patient safe and then to be able to take care of the patient. As far as the question of Versed, really with anything given to help kind of keep somebody safe and manageable, it's more a matter of how long the effect is going to last in terms of getting a good neurologic exam and evaluation with our neurosurgery colleagues in the event that we're dealing with potentially a neurosurgical emergency that needs immediate operative intervention.
Some truly take that bad, sure, because pain is bad. So that 25, they could say, and that 40 milligrams or that, or 20 milligrams, right? Well, no, so back on that. Patient unless we can driving.
And that pain dose is IV as well, and so like trying to do IV and usually not starting. So you did that go to that patient pathway.
I think the number one, the first and foremost issue is you guys' safety, right? Your safety, then the patient's safety, and whatever you need to do to maintain that that's your judgment call, and we'll support you in that. Obviously, our neurosurgery colleagues would prefer no sedation at all to get a decent neuro exam, but real life doesn't really allow for that. So I think As far as going from ketamine to Versed, I think the lowest dose of Versed that you could give in order to maintain, safety would be optimal. Again, ketamine, I've seen some paradoxical reactions with ketamine in head injured patients, so I don't think that should be a go-to thing. However, it should be in your armamentarium, so to speak. But again, the concern in the ER is a good neuro exam, but safety is what trumps everything. So I think as low dose as you possibly can would be great, but definitely, keep you guys safe.
And we're used to the neurosurgeons being disappointed in us.
And then, so with head injuries, the two biggest different head injuries is.
I'm gonna grab my mic for you.
We're still on your mic for the audience.
It's just so.
There's hypotension and hypoxia. So a single event of hypoxia or any single event of hypotension or
both of them increases their risk, their poor outcomes dramatically. And so in this regard, if you are doing medicine to help calm down the agitated patient, this is very imperative that in the trauma patient that you are supporting them, have them on monitors, have them on oxygen, watching their pressures, stuff like that, especially if you're going to give Versed or ketamine, more so with Versed, not as much with ketamine, but watching the airway, because that their outcomes are going to be drastically affected if you are giving them those medicine to calm them down and then they have that hypoxic event or they have that hypotensive event, their outcomes are much worse. So I think everybody, end tidal for sure. I think any of the surgeons, again, the neurosurgeons may be upset if they have a snowed patient coming in, but you got to do what you got to do for their safety and for the patient's safety. They're thrashing about with a potential C-spine injury that's not going to be good for them as well. But with the knowledge that this is an extra cautious patient, then after you give them that medicine, to really make sure you're monitoring them and keeping their hemodynamics supported, because they're going to have if it's a bad head injury, stuff like that, there's a lot more at stake with those.
I do a follow-up question. Is it also, if you have head injury, what is the recommended fit on those that you guys are going to see? You don't want to allow that, but a 10 out of 10 pay can't be done before as well. So it's only
Well, to speak to that, that's why I'm more of a proponent of using ketamine in the head injured patient, because you don't have the loss of airway. And oftentimes if you're given 5 or 10 of Versed, you still have to address the pain component. And so you're given 100 of fentanyl, 150 of fentanyl, and now we have a hypoxic head injured patient and you're losing the airway. And so I would err on the side of giving the ketamine over the Versed for that very reason. We know from the critical care literature, we've moved away from using benzos as sedation because we know it deteriorates their outcomes. They're not as good. So we've seen that in the pre-hospital. So I would err on the side of ketamine. But if you're giving ketamine IM, you have to wait a little longer to get the onset of action. It's not going to be as quick as an IV. So it may be those few extra minutes that you're waiting and you're like, come on, why can't we get, this person under control? So just be wary of that.
Hillary, you made a comment on what Chad said. I agree. Talking with blood pressure is really important, and trending pulse ox and title. Also, thrash is not good for your finger pressure. So you saw everybody in the room knows what's going on the line too.
Yeah.
We did have a comment that wanted to come up from Jack Mearsman. Jack would like to say that.
This is Jack Mearsman. I'm the co-chair of the Salt Lake County EMS committee. I just wanted to make a statement because I didn't hear some of the beginning, that some of the things stated here, like Hillary's dosing on pediatric TXA, in our protocols, it is still only online medical control. It's something that will be discussed to change. So it's not a standing order for field personnel that are partaking in this. Some of the things that may be said in this by some of the docs and stuff like that doesn't change what is actually written in protocol. Just wanted to throw that out there. That's all.
I'll just bring up that this is what Chief asked too, is all three of your thoughts on needle decompression, how effective it is and when to do it and where.
I was trained a more traditional environment where the needle is not helpful. And really, it's the finger in the chest. And unfortunately, in Utah, the EMS providers are not allowed to do that. In Portland, Oregon, they were. So oftentimes we get finger thoracostomies that show up in the trauma bay. That may change. We are starting to see some Nevada agencies that are starting to use finger thoracostomies, but we have what we have in Utah, which is the needle. And so if they meet the parameters of shock, and I've said that many, many times, not just decreased breath sounds, but they actually have to have shock, and you're concerned that they may have a tension pneumothorax, put the needle in. The traditional teaching was, mid-clavicular, second intercostal space. Now they're teaching more lateral. Imagine you got somebody in shock. They're going to be fight or flight. You're going to go lateral. You may get that rush of air, and then boom, they're combative again. And it may be that the needle's not working anymore because they move their arm and you can't keep their arm down. And so if you're in those scenarios, I have seen them where they're placed laterally. They don't work. Maybe another one's placed laterally, doesn't work, and then they switch to the midclavicular. But the traditional teaching now is that fourth intercostal space, which I was always trained, and I teach the residents this. If you're a Texas-sized guy like me, inframammary fold, or if you're female, inframammary fold, go out laterally, place your needle. If you're a skinny male, level of the nipple. What we don't want to do is go too low.
Dr. Amos, Jeff.
Yeah, no, just the research as far as the second intercostal space, mid-clavicular, really was showing that about half the time the catheter is not even into the pleural space. The issue with decompression is just that if there's an injury to the lung and you have increasing air accumulating with the chest, or even if it's a hemothorax, that increase in volume drives up the pressure. Pressure pushes the mediastinum to the contralateral chest. And as that happens, you get kinking off of the vena cava. You get loss of blood return to the heart. And so your preload basically goes to zero and you get rapid cardiovascular collapse. And so the whole intent and purpose is decompression, having basically a pressure pop off for that pleural space. If a needle is all that's available in the scenario you're in, great. Optimal is the finger thoracostomy, can be done in about 10 to 20 seconds. But again, it's a matter of what the state and local laws will allow to be done. With the inconsistent success rate anteriorly, ATLS has gone to teaching the lateral insertion site, basically where we would place a chest tube. The evidence suggests that that's more consistently able to be achieved, particularly in the field. And so it's really about getting that large bore catheter into the pleural space to allow for that pressure decompression as a means of kind of buying some time as you're getting the patient to the trauma center and the trauma bay. When it all comes down to it, the lateral insertion site may not be something that you're comfortable with or familiar with. If you're familiar with a second intercostal space in the midclavicular line, and there's no one else around, you got to go with what's available to you. It's in ATLS, so the ABCDE, we talk about potentially life-saving interventions, and there's only a handful of them, one of which is decompressing the pleural space, and that's through whatever means is available to you.
The only other thing that I would add is, back when I started in trauma back in the early 2000s, it was midclavicular line, second intercostal space, and, definitively, I probably had about a 25% success rate at that time. So when they moved to the anterior axillary line, fourth intercostal space, I think we got a little more success. But the thing to remember is when you needle a chest and you take out the needle, you still have a catheter in, and that catheter is not a needle. It's pretty flimsy. It's prone to kinking off. The patient moves, as they mentioned. If they start getting agitated again because you actually treated them appropriately, then it could kink off and they start having signs of shock again. So always check your equipment, just number one thing, if you do something and it worked the first time, and then for some reason something happened and the patient goes back to presenting the way they did before, always check your equipment because that catheter can be kinked off and it just needs to be either replaced by going a little bit more lateral or something else needs to be taken care of, or you need to go to a second site. So that's the only thing that the only caveat that I would recommend for needle decompression. So.
Every time a surgeon will smile if you tell them you needle them for signs of shock. Don't tell them you needle them for diminished breast health. Because they like, then you're looking for that shock component. What are you looking for? Elevated heart rate or the low saturations. But that diminished breast sound, I think that's what's in the literature, but that shouldn't be the only reason why we. Tell me if I'm wrong.
That was what Bill was saying.
Because too, if you have a pneumo it's not mentioned, you put a seal into it, there may not be any suction on it, but you probably not going to do it from second, even if it's
Not forming a tension. It's fine. But anyway, like you just want to be careful about what you're putting, when we do these interventions. I know it's been brought up. I know Addie really wants to get that involved with Salt Lake Fire. I know Scott and I are open to the idea, but just remember the amount of education and stuff like that that goes into it. And so it's that thought of doing finger thoracostomy is still out there. We're not shooting it down, but just remember that there's a lot that goes into kind of these major changes, especially with making sure we're doing it right.
There was a comment made at our trauma conference that we had in Park City a couple weeks ago, was that, you guys are allowed to do cricothyrotomies. Can't do needle. So that you're able to kind of, do an emergency airway where there's a lot of vessels and there's a lot of potential for problems, but not yet allowed to do. I mean,
The finger thoracostomy.
Yeah, seems a little.
There's a lot more here that can be injured than. And I've seen the consequences of that of carotid transections with attempts at a cric, not being familiar with the anatomy of the neck. So that's interesting that cric's allowable, but a finger thoracostomy is not.
Any considerations in front of you? Regular, legally. Just throw those extra ones up.
Shouldn't be any difference as far as needle decompression. Again, as was mentioned, making sure that you're high enough. Kind of a similar caveat is you're going in over the rib, kind of angling more cephalad toward the head. But yeah, I'm in the same boat as far as I always use the inframammary fold as the anatomic landmark that's consistent. I always thought it was interesting that we talk about the fourth intercostal space, which is an internal landmark, as it makes no sense because what we have to work with is what we can see externally. And so, yeah, the inframammary fold is pretty consistent, male or female, body habitus wise. And usually that level or a few centimeters above, you should be okay, even in a pregnant female.
And I would say, make sure that what you're saying is, it's near me. Signs of shock are not from the fact that you just need to displace the uterus. So if you have them in the back of the truck on their back and they're shocky, push the uterus away from the inferior vena cava, and that may fix your problem. If it doesn't, then keep moving, but make sure that you're not they're in shock, and they are in shock because their inferior vena cava is compressed.
When you use the inframammary fold as a location, are you finding the intercostal and following it around, or are you just going straight lateral from where that mammary threshold is?
Usually just straight lateral into mid-axillary, anterior axillary, kind of that region, out laterally. You just follow it straight out lateral, find if you can palpate a rib where you're going to be able to go over the top of the rib so you're avoiding the artery and nerve that run on the underside of the rib.
I have a question about if you suspect a ruptured diaphragm is causing some of your patient's symptoms. Like, I know you can't differentiate in the field, but I don't know, I'm just, I've had someone who actually, when they put in the needle, they actually fish because they have ruptured diaphragm, they fish the intestines.
Yeah, in theory, you shouldn't develop tension with a ruptured diaphragm.
Gotcha.
Because you're decompressing whatever's there into the abdominal cavity. So you're not going to have, your shock is from a different reason.
But that's where you would have decreased breath sounds maybe, or like adventitious breath sounds in the chest. So, I mean,
I think breath sounds are a real terrible thing to go off of. Just, I mean, how quiet is it really? Or, if there's a helicopter around or that, you're on a highway, something like that. So it really is your clinical picture.
I have one more question for you. What are some of the good things and what are some of the bad things or things that we could improve on as EMS that you guys see coming into the trauma base? It could be patient handoff or any of those things. Where are we strong and where is EMS really improving?
So no, I think that's as level 1 and level 2 centers, we are interacting with all kinds of EMS agencies, air transport agencies. I think that's the difficult thing is the region that we serve, the number of both kind of municipal but also private companies that are involved in patient transport. It leads to a lot of variability in terms of the way things are done and communicated. I think that's probably where the greatest opportunity is kind of streamlining and standardizing the sign over and the sign out. We want to be able to give you opportunity to communicate the important details of the blood, sweat, and tears you've put into the care of your patient, but to do it in a streamlined fashion. Sometimes we have a lot of details that aren't really particularly pertinent to the situation, and that can sometimes delay kind of the attention we need to provide to the patient. So I think that's probably the biggest area for opportunity for improvement is just if we were able to standardize, whether it's the MIST, whether it's something else, the pass off of information. Otherwise, no, it's amazing the work that you do. Amazing what you all are capable of. We have patients come in. We just had a 20-year-old kid last week come in, roll over, ejected, the car rolled over the top of him, traumatic amputation of his arm, near amputation of his left leg. And he comes in able to interact and speak with us. I mean, it's amazing to me what you deal with that we don't always get to appreciate in the trauma base. So no, just kudos and mad respect for what you do. And it's not our place to sit and be critical of what's going on beforehand, because we would be soiling ourselves in that same environment the majority of the time.
I would second that. I've worked in multiple different trauma centers from the U to Utah Valley to now St. Mark's. And, EMS is the one thing that's been consistent is you guys' desire to learn and improve what you do and how you provide patient care. And I think most of the time, you guys do great. I mean, obviously, there's sometimes that we can provide feedback and help all of us provide more consistent and higher quality patient care. But most of the time, what I've found is you guys need to provide us feedback with how we receive you. Sometimes in the chaos of the trauma bay, you're trying to give report and there's, chaos going on because, you got nurses trying to put IVs in or check IVs or check blood pressures. You've got an ER doc, maintaining the airway, and you've got anesthesiology and you've got trauma surgeon, and they're all kind of trying to exert their influence. And you're just trying to give report. You're just trying to say, look, this is what we found on scene. This is what happened en route. And so a lot of times, your feedback to us is extremely important because you provide a service that is invaluable, and we appreciate that. And even though there's times when we may not give you the attention you deserve, we want that feedback as well. But for the most part, you guys are doing fantastic. And if anything does come up, you're extremely open to feedback. We appreciate that. And it's a pleasure working with all you guys.
I would agree. As trauma medical director, I get the requests for reviews of, kind of the handoff or incidents that occur in our center. And no, those are opportunities to get to know each other better, to understand each other's roles better, to understand the challenges that we face in our roles. And more often than not, if we approach it with the right attitude of wanting to collaborate and work together better, I love the relationships that we develop with our EMS crews. If we take the right attitude about it, not getting defensive about, we're there trying to save a life. And no, it's an opportunity to look for where we can improve what we're doing. And most importantly, how we can interact and collaborate for the benefit of our patients. And so, yeah, by all means, if there are issues or opportunities, we welcome that dialogue and welcome that feedback as a means of getting to know each other better and further strengthen the ties that we have with the crews that we interact with.
I know you've heard me say it many, many times, but you are a member of the trauma team, and the care of the trauma patient starts with you guys on scene, and hopefully it ends up years later in a primary care clinic. I agree with everything that was said. The only thing that I would add as a caveat is it would be nice if the state 2B protocol, if that was the standard. I know that there's some differences in agencies and differences in medical control of medications and things, but creating some standardization protocols makes it a lot easier. And I think that this is a huge step in the right direction to do this for trauma. And hopefully it's a stepping stone to other protocols that may be within the 2B realm.
On that note, what is the best way to get hold of you guys to kind of meet with you and talking about that kind of stuff? Is that like going through our EMS liaison or with you guys? So, okay.
Well, if we were you.
I mean, I don't really want feedback from you guys. You guys just.
You know where this stuff patients.
Yeah. Yeah, we get a ton of that stuff from you guys, but like, yeah. Okay, perfect.
Yeah, and depending on the situation, we try to take a moment to pull you on over to look at imaging or whatnot, or to be able to do a little bit of a debrief there in the bay, depending on the scenario. But yeah, by all means, whether it's a venue like this, whether it's an opportunity to come up and spend a morning with the team, kind of seeing what the trauma team does. There's a whole lot that we get to do. It really lends itself to our ADHD nature. One moment we're in the trauma bay, the next we're in the OR, the next we're in clinic. So, but it's, again, to that end of understanding each other better the roles and the strain and stress that we experience in those roles, I think helps us to work together and streamline kind of that collaboration together much more effectively. So yeah, by all means, love interacting with y'all.
So on the feedback I send, if there's ever an unanswered question, because I go for what I think you're asking for, but I'm not there at the scene, so I don't know. So if you say thanks for the feedback, but you didn't answer my question, please reach back out. I'm happy to clarify that. Do the best I can with what I have, so.
And you guys' feedback is always awesome. It's just meeting with these guys directly to say, how did this go? What could we have done to do something maybe?
Yeah.
We have a report after.
We're always happy to do case reviews as well. So the same thing, you just collaborate with us. Be like, hey, can we do a case review? And if it's a night, if it's a good case, let's all get together again, right? And talk about it. Or if we've had ones where we had a patient go to St. Mark's and a patient go to the U. So we got together and did that case review and training together with the docs from the U, the docs from St. Mark's and us. So I'm happy to do that.
Those case reviews are awesome because, it's not only just giving you guys the feedback that you need, it's giving them the feedback they need from you. It goes both ways.
I was just gonna add, we're very interested in your well-being and your health. So even an informal inquiry for some closure, we're happy to talk to your team and just kind of follow up with you and let you know. The big role of ours. Well, I think that's why that feedback is important too, for you to be able to close that loop of what you've done here. Support for you as well.
And I know that all of our people in this room that are liaisons with BMS, I know you have to follow the chain of command a lot of the time, but you are welcome to call us directly. And say, hey, we just want to know what happened. We'll still send you all the formal stuff, but.
And if you do call us directly, we're still going to keep your EMS chief involved.
Well, I think the other thing is, in all the facilities I've worked at, even back when I worked at the U and the Jeff Saffel and Rich Barton era, if you see a trauma surgeon, in the hallway, and even after you've dropped off a patient or anything, they're always open to, talking to you. If you have a question, a concern, anything like that, something you want to talk to them about, whether it's positive, negative, whatever. I've never worked with a trauma surgeon that is not open to some kind of conversation with you guys, because as was mentioned, you guys are part of the trauma team. That's the bottom line. So don't hesitate to reach out to us if you see us in the hallway.
I don't deal with you guys really ever, but if you do happen to bring somebody up to the U, I'm very happy to also come by the station as well. And give you guys any feedback, pull up imaging. I do that with the Salt Lake crews all the time when they bring people in, because I know that the trauma team is generally busy and I'm normally kind of just hanging out. And so I often will pull up the images or kind of walk through the process, because a lot of the feedback I get, kind of the negative feedback, is they feel like they weren't being heard. But then I try to kind of bridge over and say, well, you have to recognize that, we still have to do our primary, secondary, mainly primary survey, because there's a lot of key information. Like, are we going right to the OR? Are we getting imaging? Are we having to place extra lines or stuff like that? And so that takes priority, obviously. Just like when you guys get on scene, you have your primary survey you're doing. They have their primary survey, and most of the time they're busy. And it's not that they don't want to talk. It's just that they have to kind of check boxes. So that's where I kind of will try to kind of give anything. And so the Salt Lake guys always reach out, and they always have questions. We have a feedback process, not only through the trauma team, but also through me. So if you guys ever happen to bring somebody up to the U, I'm more than happy to do that with you guys too. But it's kind of hard when you guys are literally next door to the trauma center. But in regards to the 2B protocols, that is something that I know that a lot of Scott, Graham, I know that's, again, not you guys, but with UFA, with Salt Lake City, West Valley, we're trying to standardize the approach of things. And it's been awesome. At least I've been fortunate that as I took on this director 2B thing or whatever I am, chair of the 2B committee, voluntold to be chair of the 2B committee. I missed the meeting, and the next thing I know, I was the committee chair.
You missed the meeting.
I know. It's been awesome that the group that's been trying to do these protocols and review them, there's a lot of work that's been done that they've been doing that makes my life super easy. And I think that this is step one that's been awesome about really trying to revamp and standardize the processes. So that should you guys come up to the U, we're getting the same type of patient as if you go to IMC versus going to St. Mark's or wherever you're going. And we know that the different agencies bringing in are also training to that same standard as well. So this has been awesome. So I appreciate all the work that's gone into it. And for those that maybe aren't aware of all that work they've done, definitely take a second to like recognize how much they really try to help and be advocates. Because it's one thing to have me sit behind my desk and to write a bunch of protocols and say, this is what you're doing. But it's another for your own boots on the ground people to be saying, hey, this is what I'm seeing. And I mean, I was a paramedic back in the day. You know, I'm not that old, but back in the day, but like things changed so much. We didn't have TXA back then, things like that. And so what they're doing is awesome. And so keep plugging them. If you notice stuff or protocols or things like that, or you want to do it, like keep plugging them and they'll bring it up to me and the other people. And, you know, we'll keep trying to modify and try to keep the, you know, the conversation going about how to improve it all together, or we'll at least try to give you a reason why we're not doing it. A real reason, not just a, we're not doing that. So. Also, having all of your trauma surgeons here is also amazing. Where I was a paramedic, I couldn't tell you the name of any of my trauma surgeons. They just weren't accessible. And so having them in the flesh, putting a face to a name and stuff like that is super helpful as well. So.
Any final thoughts from you guys on this protocol specifically? Where you guys let them go the penetrating versus want the rest, or anything to talk about?
No, just grateful to have been able to be part of kind of the different drafts that were kind of talked and discussed through. But yeah, this is tremendous to try to standardize the care across multiple agencies.
No questions online? Yes, no.
Thank you guys so much for coming out today and taking time out of your busy schedules. We really appreciate it as a valley. Definitely my advice. Thank you.
Thank you.
Yep, thank you very much.
Should have.
Yeah.
But